Welcome to Medicine Grand Rounds. Congratulations to all the residents matching into their fellowships today. Should be finding out right now. Yeah, they probably know right now. Yeah. I'm Dr. Sutherland. I'm one of the chief residents here. I'll be introducing our speakers for today. Our first speaker is Dr. Shukla. She graduated from the University of Miami with her bachelor's degree and stayed at the Miller School of Medicine to complete her medical degree. Following medical school, she went to Houston, Texas to complete her internal medicine residency at Baylor College of Medicine, after which she returned to the University of Miami and Jackson to complete her subspecialty training in gastroenterology and hepatology. After graduating, she joined the Division of Digestive Health with the University of Miami as a teaching faculty member, focusing on general GI at Jackson Memorial Hospital. She's also one of the longitudinal clinical educators with the Next Gen curriculum. She currently serves as Director of Quality and Patient Safety for the GI Department at Jackson Memorial Hospital. Dr. Shukla will be speaking today about a localized approach to Helicobacter pylori.
Thank you, Kyle, for the introduction. Today, and thank you for the opportunity to speak. Today, I'm going to be talking about Helicobacter pylori. And so over the next, over the next 20 to 25 minutes, I'm going to briefly discuss the usual approach to H. pylori, then try to spend a little bit of time to talk about trends in antibiotic resistance and to discuss local management considerations for H. pylori. So what is H. pylori? H. pylori is a gram-negative rod. It has multiple characteristics that allow it to survive the harsh environment in the lumen of the stomach until it reaches below the mucus layer. And it also has characteristics that allow it to evade the immune system. We won't go too much in detail today, but so why should we care about H. pylori? So these are the complications. H. pylori is a modifiable risk factor for peptic ulcer disease, gastric adenocarcinoma. We all know that there is morbidity, mortality associated with these two conditions. Specifically for peptic ulcer disease, H. pylori can be attributed to up to 90% of gastric ulcers and upwards of 60%, of duodenal ulcers, 90% of duodenal, upwards of 60% of gastric ulcers. And when considering gastric adenocarcinoma, H. pylori can be attributed to over 85% of non-cardiac gastric cancer. When looking at infectious carcinogenic pathogens, H. pylori, of the over 2 million cancers, 2.2 million cancers worldwide from infectious pathogens, H. pylori is responsible for 37% of those. So that's more than hepatitis B, hepatitis C combined. So now I'll talk a little bit about the global prevalence of H. pylori. Why is this important? Well, most of us, or some of us, know that H. pylori is acquired in childhood. So H. pylori, people retain the risk factors from where they are born, from their birth country. And in somewhere like Miami-Dade County, where over 50% of individuals are foreign born, this is important to kind of be aware of this information. So overall, 4 billion people in the world are estimated to be infected with H. pylori. And in this meta-analysis, they looked at different regions. And I'll highlight 2 regions specifically. So in North America, the prevalence is thought to be 37%. And in Latin America and the Caribbean, the prevalence, although thought to be underestimated, about 63%. And so we can suspect in Miami-Dade, our prevalence is somewhere kind of in between there. And one of my colleagues, Dr. Shriya Kumar, is trying to look at the prevalence in our community a little closer. So who should be tested? So from now on in the presentation, I'm going to switch to focusing on the Western guidelines, so European, North American guidelines. The Eastern guidelines are a little different due to the higher incidence of gastric cancer due to different strains of H. pylori in the East, and different antibiotic resistance, different availability of antibiotics. So in general, the guidelines agree on certain things. There are some differences. So overall, they agree that everyone with ulcer disease, early gastric cancer, dyspepsia should be tested for H. pylori. There are some differences. I'll mention that the Houston Consensus Conference in their single iteration from 2018 was a little more liberal. They say that we should suggest testing patients of Latino and African American racial and ethnic groups, in addition to first-generation immigrants from high prevalence areas. So switching over to diagnosis. So in general, we have the non-invasive tests, which includes urea, breath test, stool antigen, very easy for patients to perform. Stool PCR is a little new and therefore is not as widely available, but can do PCR for antibiotic resistance. And then we have endoscopy with biopsy. And there are different ways to assess for H. pylori on biopsy specimens. Here at our institutions, they mostly use histology. Very importantly, all testing should be done off of PPI for 2 weeks, antibiotics and bismuth for 4 weeks. And this is because PPI can decrease the density of the H. pylori above the mucus layer. And antibiotics, bismuth are bactericidal. They can obviously cause false negatives as with PPI. And you may notice here that I don't mention serology. Serology is not recommended for diagnosis of H. pylori due to concerns of sensitivity and inability to distinguish active versus prior past infection. So for performance characteristics of these tests that are currently available, really here the take-home point is that non-invasive tests perform well. Overall, they've been shown to have greater than 90 to 95% sensitivity. They're generally covered by insurances, and then endoscopic tests or invasive tests are covered if medically necessary. I'll mention gastric biopsy with culture here. The guidelines refer to this a lot. However, it is not readily available due to multiple reasons. It requires a lot of, from the beginning with biopsy, it requires special specimen handling, special media. The biopsy specimens have to be frozen at -70 degrees and Celsius, and then they have to, in most cases, have to be transferred to another lab. These organisms are not cultured in-house because they require special techniques, special environments, and therefore there's only a few labs across the US that actually do this culture. And therefore, even though the sensitivity here is listed as 90% in the literature, I think in real life, I think most people, in my experience, it's been closer to 60% probably. And therefore, it's more expensive, and we don't have as much information on antibiotic resistance susceptibility. So switching to recommendations for first-line therapy, unlike a lot of other infectious organisms, H. pylori is still treated empirically. So for empiric therapy, we generally have a backbone of acid suppressive medication, 2 to 3 antibiotics, and sometimes bismuth. Bismuth itself is bactericidal and can work synergistically with the antibiotics. And the PPI therapy actually brings the H. pylori into the replicative phase, so the antibiotics can work a little better for for eradication. So all guidelines agree that we should consider prior antibiotic exposures and avoid the same antibiotics. So, and that includes antibiotics for any indication. So a good history is important here. We should consider local resistance patterns, although we already mentioned why a lot of that information may not be available. And all of the guidelines agree that if clarithromycin resistance is greater than 15%, then we should avoid empiric triple clarithromycin-based therapy. So this is a summary of the Western guidelines for first-line therapy. I know there's a lot of text here, but really they are very similar in what they recommend for first-line therapy. So clarithromycin-based triple therapy if the local resistance is low, and then a bismuth-based therapy with metronidazole tetracycline, referred to by a lot as quadruple therapy. And another recommended regimen is concomitant therapy, which includes 3 antibiotics. The ACG has a few other suggestions, but none of the other guidelines recommend those for first line. So what are we prescribing? So here, first in the US, this was from a review of insurance claims data of 41,000 patients between 2016 and 2019, at a time where there was some evidence of emerging resistance of clarithromycin. You see that 80% of providers were giving clarithromycin-based therapy. And at UHealth, around a similar time in 1,200 patients, we saw a similar pattern of prescription pattern. So now switching over to antibiotic resistance, we'll look first from a worldwide view, then kind of looking at the US and regionally, and then kind of locally a little bit. So here, this is from a meta-analysis in 2018 that looked at clarithromycin, metronidazole, and levofloxacin resistance across the US. First, you can see here that there's a lot of missing data, even in areas where the prevalence of H. pylori is high. So in the US, clarithromycin resistance is suspected to be between 20 to 30% based on the data available, metronidazole 10 to 20%, and levofloxacin 20 to 30% as well. So how has this resistance changed over time? So in that same meta-analysis, they looked at regions and changes over time. So in the Americas region, between 2006 and 2016, they did see that changes from clarithromycin resistance from 9 to 11 range up to 20%. This has been seen in other regions as well and other studies. So now looking a little more regionally, what information do we have about local resistance? So this was published this year. This was from a patient population that was treatment naive. About in the US arm, it was about 380 patients. They were tested for cultured and tested for antibiotic susceptibility resistance in 2018, 2019. And there was 189 patients specifically from the US Southeast. And when looking at the recruitment locations, of the top 25 recruitment facilities, 5 of those were from Miami. And so our population is represented in this sample. So really what you can see here is that 25% in the Southeast region were resistant to clarithromycin and 67% to metronidazole. So what about even at a more local level? So with some support, I was fortunate enough to be able to look at the resistance for H. pylori in a cohort of 40 patients at Jackson Memorial Hospital that came in for routine endoscopy with biopsy between 2020 and 2023. So here, in this population, the clarithromycin resistance mirrored very similar to what was found regionally in the larger sample. The levofloxacin resistance here was almost 50%, and there was no resistance to metronidazole, which we're still needs to be explored more. And so I mentioned that antibiotic resistance testing, susceptibility testing is not readily available. And therefore, experts have started to recommend looking at test of cure data institutionally, regionally, as a surrogate for how well these regimens are working. And when we look at this in 618 patients that were treated for H. pylori with eradication testing at UHealth, we see that of the top 3 used regimens, they all had eradication success less than 75%. So we still have work to do. The most common reasons for failure of eradication are antibiotic resistance and adherence problems, and we'll talk a little more about that later. So what guideline-based first-line therapy should we consider in South Florida? So this is basically the same chart, although I think there is a lot of evidence that suggests that we should remove the triple therapy with clarithromycin. And so the bismuth-based quadruple therapy and the concomitant therapy should be considered. However, we should consider antibiotic stewardship when using concomitant therapy because at least one of those 3 antibiotics probably is unnecessary. What about rifabutin-based therapy? So this therapy is not included in the guidelines, possibly because this paper, this study published in 2020 in the Annals of Internal Medicine was done after the most recent iteration of a lot of those guidelines. This was done in the US. It compared high-dose amoxicillin, omeprazole, and a delayed-release rifabutin with high-dose omeprazole and amoxicillin. And really the take-home point here is that the eradication rate in the rifabutin group was 83% and up to 90% in the confirmed adherent population. And because of this information and the ability of this regimen to avoid emerging clarithromycin, levofloxacin resistance, a lot of thought leaders in the US are recommending this as first-line therapy. So putting all of this together, what should we use as empiric first-line therapy in our community? So I think the bismuth-based quadruple therapy is really what we should reach for first if possible. Notably, this also is a good regimen for those that may be penicillin allergic initially. And then another good option is the rifabutin-based therapy. And finally, if those two aren't possible, then considering the concomitant therapy, but trying to avoid due to concerns for antibiotic stewardship. So let's talk practically a little bit. Pill burden and costs. Those of you that have prescribed H. pylori therapy may have discussed this with their patients. But first, you can see the frequency of the doses for these medications ranges from, for these regimens, from twice a day to 4 times a day, and sometimes differing times. The cost is also a concern. So you can see that there are 2 branded combo pills. You may have heard of Panara, is the quadruple therapy bismuth-based, and the rifabutin-based combo Talicia. Both of those are cost prohibitive due to the cost of about $1,000. The Pylori is available at Jackson for patients there. It's sometimes covered on some Medicaid plans, but not on some Medicare plans. And the Talicia isn't generally covered. You also see even in bismuth quadruple therapy, tetracycline can be expensive, and you can substitute it with doxycycline, although it performs a little less better than tetracycline. If no other options, you can consider that. So assessing for eradication. We should be assessing for eradication in all patients. This is not just important for the individual, but also for information for your institution, for regional, looking at how well these regimens are doing. So now I'll switch a little bit for the last few minutes to refractory H. pylori infection, and then talk about some things on the horizon. So you may have heard of different ways to refer to refractory H. pylori infection: second-line therapy, third-line salvage therapy. But to kind of simplify it, this is a definition from the AGA Clinical Practice Update. Really, any infection that is persistent after you've completed more than 1 course of guideline-based therapy is considered refractory. So what contributes to eradication failure? So I already mentioned antibiotic resistance. So in some antibiotics will work better in recurrent eradication attempts, and some will work worse. So specifically, macrolides and fluoroquinolones, if a patient is resistant to those medications, if an organism is, then there is an odds of 7 to 8 times failure with these medications if reusing them. But when you reusing the nitroimidazole group, the metronidazole is what we use, it's only 2.5 times odds ratio of failure if that's previously been used or you're resistant. And therefore, metronidazole is for when treating refractory infection, is sometimes we're able to overcome the resistance by increasing the doses. It works synergistically with bismuth as well. So non-adherence is another problem. There's actually data that suggests that discussing with your patients about what to expect, the doses to expect, the adverse effects, the importance of taking this can actually improve adherence. So we should be doing that with all of our patients. Finally, I'll talk a little bit about pH. pH is really important. We talked about how the gastric pH needs to be a little higher for these medications to work optimally. There's a polymorphism in the CYP2C19, which can cause rapid metabolism of PPIs, possibly more common in the West than in the East, and it affects older generation PPIs more. So switching to a newer generation PPI, if possible, would be preferred for a repeat attempt at eradication. And finally, all PPIs don't have the same potency, so you can consider potency when choosing another PPI as well. So potassium competitive acid blockers. So new kid on the block. This was the H. pylori regimens with vonoprazan, if you've heard of it, were approved by the FDA in 2022. That was both a triple therapy with clarithromycin and a dual therapy. And this month was approved for erosive esophagitis and may actually be available in the US as early as next month. So what's different about this class? Compared to PPIs, they have a longer half-life, so more durable, a quicker onset, and they're not affected by the CYP2C19 polymorphism. So this was the trial that led to the approval in the US. It looked at a dual therapy with vonoprazan, so vonoprazan and amoxicillin, and then vonoprazan, amoxicillin, clarithromycin with a traditional PPI, amoxicillin, clarithromycin. And here what it did show is in that the clarithromycin resistant group and in the overall group that the vonoprazan-based therapy worked better, was superior. And therefore, we look forward to kind of adding this to our tool belt, and we'll see how this is going to fit in the algorithms going forward once it's available. And so finally, what is the role and goals of antibiotic susceptibility testing? So we talked about antibiotic stewardship, and susceptibility testing is very important for that. But when considering treatment, meta-analyses have actually shown that susceptibility-guided treatment is not better over empirical treatment with a bismuth-based quadruple therapy in either first-line or second-line therapies. However, after second-line empiric therapy, you should consider susceptibility testing, referring to an expert. Finally, the take-home points for today. So non-invasive tests for H. pylori have good sensitivity if done off PPI therapy for at least 14 days. You should use a bismuth-based quadruple therapy for first-line empiric therapy in our community. Providers prescribing H. pylori therapy should give anticipatory guidance explaining the rationale for therapy, dosing instructions, expected adverse events, and the importance of completing the full therapeutic course. Avoid macrolide or fluoroquinolone-based triple therapies or therapies at all if these antibiotics were previously used. And refer to the expert for antibiotic susceptibility testing if two empiric failures. And finally, check for eradication for patient-specific benefits and for surveillance of effectiveness of therapy in the local population. Thank you very much.
Thank you, Dr. Shukla. That was very didactic, clear, and excellent review of the topic. I can begin by asking one question, perhaps. Can you enlighten us a little bit about the molecular testing? So if you're going to screen a molecular isolate and not culture it, but what is the rationale of do they look at the whole genome, or are there certain cassettes that are known to be associated with the resistance? How is that looked at?
Yeah, so there's certain areas that they look for. They're actually more reliable, I believe, for the clarithromycin and levofloxacin, but maybe for metronidazole less reliable. But yeah, there's certain areas that they look for.
Questions on the chat? Well, let me ask one more question then, because this is really exciting. we talked about the era of personalized medicine. So if I were a Helicobacter, I'd be really scared now because you're personalizing it against me. But how do we look at the patient? Are there certain, other than geographic locations, are there certain ways in which we can tailor the treatment based on what we know about the patient, either their genome, their social determinants of disease, or whatever?
Yeah, so not personalized as well. We do know that social determinants of health factor in to eradication failure. Some studies have looked at even, I think it was in New Jersey, a socially disadvantaged neighborhood, and eradication was poor there. In terms of personalized medicine, I think the CYP2C19, looking at that and maybe trying to choose which PPIs may be better for certain patients. However, they're not routinely doing that anywhere, I believe. But no way to specifically know which patients will respond other than antibiotic susceptibility testing.
Great, thank you so much. And there are 80 people online, so you shouldn't think this is the entirety of your audience.
Is there time for another question or not? No? All right.
Go ahead, we have time for one. Who is that?
Yeah, this is Dr. Colbert. A quick question in terms of a number of years ago, I was trained to start with a PPI before we began the other medications. I guess that's passé now.
Yeah, so for those that don't know, H. pylori is less than, like, the discovery was less than 50 years ago. So we've come a long way in the time. Initially, it was started with just PPI, one antibiotic, and very quickly before 2000, we realized that they needed more antibiotics to treat it. So yeah, because of the environment, the harsh environment there, we really need multiple organisms, but hopefully we can tailor that a little better so we can focus on antibiotic stewardship a little better while treating our patients.
Thank you, Kyle.
All right, thank you. For our second speaker, we have Dr. Gorman. Dr. Gorman joined faculty at Department of Pulmonary and Critical Care Medicine in August of 2022. Prior to that, he completed his fellowship in critical care medicine at Cooper University Hospital in Camden, New Jersey. He is board certified in emergency medicine, critical care medicine, and echocardiography. At Dr. Gorman works in both the MICU and CVICU, and in addition to the Jackson MICU. He currently serves as the medical director for the Pulmonary Embolism Response Team at UMH. He has special interest in echocardiography, advanced hemodynamics and resuscitation, mechanical circulatory support, and post-cardiac surgery management. Dr. Gorman will be talking today about catheter-directed therapies for pulmonary embolism.
Okay, so how's the audio in the room? You can hear me okay? All right, so I'm going to go over catheter-directed therapies for PE, keeping it relevant to all walks of medicine. It's such a prevalent disease, especially at UHealth with the oncologic population we have. So I will go over all the spectrum of disease process. If I can move the slides. So no financial disclosures. There are a lot of brand names that I'm going to be mentioning with the devices and the different interventions. I don't have any financial interest in these devices. As we said, I'm the medical director at UMH for PERT. I'm the site PI for the Consortium National Registry that we are a part of. And we're an investigating site at some of the trials. I don't have an authorship interest in any of these trials as well. So I'm free of disclosures overall. So quick objectives, we're going to go over some of the guidelines, talk about PE classification, go over a little bit of the terminology so everybody's familiar with the indications and contraindications for all of these therapies, and then talk about mainly the catheter therapies. So IVC filters, catheter-directed thrombolysis, catheter-directed thrombectomy, aspiration and mechanical, and then talk about some current research projects that are ongoing. So there's 5 basic guidelines that I'll be referencing in the presentation. There's more. These are the main ones that you'll see nationally at big centers that have PERT programs. The AHA has a guideline that was from 2011, and it's been updated since it was in circulation. The European Society of Cardiology, or ESC, has a 2019 guideline that they updated in 2020. The PERT Consortium, which is a group of hospitals that are invested nationally in PE research and involving PE therapy, they have a guideline as well. American College of Chest, so pulmonary and critical care physicians have a guideline from 2021. And then the proceduralists that are involved frequently both at our hospital and nationally, the Society of Interventional Radiology, they have a guideline that was published in 2018. So classification is kind of agreed upon, just so everybody's on the same page. You have your 4 basic branches of pulmonary emboli. So you have your massive PE that I think most people are familiar with. Those are the unstable, persistent hypotension, need for vasopressors, ICU level care. Those patients are considered massive. Submassive or intermediate risk, depending on the literature you're reading, those 2 terms are interchangeable. I will use submassive because that's the terminology I prefer. That is the middle category, and then low risk is the last category. And really, you're looking at 2 things. You're looking at RV strain, either on CAT scan or echo, and you're looking at myocardial necrosis, and that's with an elevated troponin. If you have both, then you fall into the submassive high risk category. If you have one or the other, you are submassive low risk. If you have neither, you're the low risk PE. And that is independent of size, and that's a common misconception that is based on the location of the PE. So you can have a proximal PE that might be chronic, but you have no biomarker elevation and a normal RV, you're in a low risk category. So for the major classification and the management plan, this is from our handbook that we use that's developed from the AHA, ESC, and the PERT Consortium. What you really care about are your bleeding risk for your patient, high or moderate, and your TPA contraindications. And this basically categorizes what therapies are available to this patient, what can I do if they get worse, and what can I do knowing their background. And if you look at all this extensive list, at UMH, I would say 70% of our PERT patients in the past year have at least something on these 2 lists. So it's very common, and it really guides your management because you're really not able to give the aggressive therapy or even the intermediate therapy in some patients, or you're not able to give any therapy essentially because some patients can't even tolerate anticoagulation. So that's when PERT teams are more important in these really complex patients that have a lot of multiple risk factors for bleeding and TPA contraindications. So here's our management protocol. I'm using this mainly to kind of go over the current practice. So if you're on this left category in the massive and you're able to get systemic thrombolysis, you get systemic thrombolysis. It's a class recommendation for ESC, AHA. It's universally agreed upon, well studied. If you're on the right, my right, anticoagulation is the mainstay, also a class 1. So if you're in that low risk or the submassive low risk, that management is more straightforward. It's anticoagulation. And again, it all becomes blurry and gray and evidence-free when the patient can't get anticoagulation at all, or if they are a massive or a submassive high risk and they can't get thrombolytics. So that's really when the multidisciplinary discussion is important. So let's get into the main part of the presentation. So catheter-directed therapies, I broke down into 5 different types. So one is IVC filter. These are very commonly used. You'll see these on the outpatient setting, on the inpatient setting. Lysis infusion catheters, or CDT, that's when TPA is infused, generally at a lower dose, directly into the pulmonary artery by either interventional cardiologist or interventional radiologist. ECOS, or ultrasound assisted, that's basically you combine ultrasound waves at high frequency to assist with breaking up the clot while infusing TPA at a lower dose. And then mechanical thrombectomy and aspiration thrombectomy, those are no TPA derivatives. And that involves either aspiration or mechanical with a type of device or wire or coil to remove the thrombus. So let's talk about IVC filters, very commonly used, like I said. Your indications, and these are the ones that you'll see on the floor, you'll see in the outpatient, a patient might have an IVC filter that they were discharged with. And the question is, do they still need it, or did they need it in the first place? The main indication that we kind of follow and we recommend with our team are the high-risk DVT with absolute contraindications to anticoagulation. So they can't get anticoagulated because they just had a neurologic surgery, they just had a spinal surgery, they have an absolute active GI bleed or similar, and they hemorrhagic stroke, and they can't get anticoagulation whatsoever. So those patients, it is a class 1 recommendation from the AHA to get an IVC filter. Then it gets a little less agreed upon down the list. So acute PE, even in absence of a DVT diagnosis, the AHA still recommends an IVC filter if you can't be on any anticoagulation. The thought process is you're going to potentially have a DVT there, or you'll develop a DVT there that can embolize and cause even further strain on the right heart. Recurrent PEs, despite anticoagulation, is a class 2A, so it's getting less firm recommendation, but that's still a situation. And then a large free-floating proximal DVT, so the big common femoral ones with a large moving tip. And I use the PERT consortium word of consider. So it's kind of that, yes, the evidence isn't great, but it might benefit your patient, especially if maybe they do have a bleeding risk and you don't want to empirically go to the higher dosing. Contraindications, and this is chest as our recommendation. This is kind of what we follow with our PERT team at UMH. If you can get anticoagulation, the evidence doesn't really support using IVC filter. And I'll talk about the 3 major trials supporting that. This is, for reference, this is a patient with an IVC filter. If I can get the video to play, hopefully I can. It's not available, but anyway. So this is an ECMO cannula going through an IVC filter that's 28 French. So it's a centimeter diameter, and the filter didn't catch it, and you can go right through. So that's a pretty large, potentially DVT that could embolize that it's not doing anything for. So this was a UMH patient that I like to show as a kind of a guideline for how big these holes are in these baskets. Let's see if I can go back, sorry. So the first big RCT for IVC filters was PREPIC. It was out of France. There's 44 studies, multi-center, open label RCT, and it was basically filter versus no filter. And you had to have an acute proximal DVT. And what this showed is it did reduce the rates of PEs at 12 days, but it also increases your DVT risk over 2 years. And in this study, the contraindication to anticoagulation actually excluded you. So this is patients that got anticoagulation most of the time, filter versus no filter. So yes, it reduces that PE risk in the immediate 2-week span, but over 2 years, your DVT risk actually elevates. And so that led to the practice at the time. And then the same group did another trial in 2015, also out of France, less centers. This was another RCT, and this was evaluating a DVT PE and anticoagulation versus anticoagulation plus a filter. And the outcomes were the same over 6 months. So no change in PE or DVT and at 3 months, and no change in PE or DVT at 6 months. So this kind of led to the practice pattern that says, if you can get anticoagulation, you probably won't benefit from that IVC filter, and you might actually be harmed by it. So especially in the outpatient center and on rounds with me, if we have patients that have an IVC filter that don't have a contraindication any longer, say their active GI bleed is no longer there, or their platelets are no longer 10, now they're 100, and you can do anticoagulation, that filter should be removed because it does increase your risk over time. And the longer they're in, the more difficult it is to remove them because they become epithelialized to the IVC. There's a trial this year that I wanted to mention, spend a little more time on. This was more of the safety with all these different brands, less pertinent to placing or removing, but the recurrent DVT risk was very low, and the recurrent PE risk was also very low, and the perforation risk was even lower, so less than 1% perforation risk. So this trial basically focused on a prospective look at how safe these devices are. So they're pretty safe, but you have to have the right indications, are kind of the summary that we have that we follow on our algorithm. So let's talk about the catheter-directed thrombolysis, or CDT. So the confusing thing for, I think, everybody is CDT, meaning catheter-directed thrombectomy, but normally in all the trials and the studies, and when we talk about it, that means thrombolysis. So that means you have an infusion catheter that's delivering a lower dose of TPA than you would systemically directly into the pulmonary artery. The main ones that you'll see, there's plenty of devices, are Angiojet from Boston Scientific. Boston Scientific also has an ECOS, which uses the ultrasound, like I mentioned previously, to assist with breaking up the thrombus. And this is a Medtronic Craig McNamara infusion catheter. You can use standard infusion catheters, and there's numerous. So the indications here, these really come into play if you have a massive PE and a relative contraindication to systemic thrombolysis. So you can't get full dose systemically. You have risk factors for bleeding, but you still probably need TPA because you're a very sick massive PE patient. So these are very helpful there. And ESC and AHA kind of agree a 2AC recommendation. The trials are limited because a lot of these are single arm prospective industry-sponsored studies instead of an RCT. So it's going to have that C recommendation. But this is a situation where we use it fairly frequently. Massive PE without improvement to systemic thrombolysis, that's another one. So you get TPA, instead of redosing systemically, if you're still very sick, then we can place a more catheter-directed one. Then submassive high risk, that is kind of the gray area that's continuing to be studied because you want to prevent them from getting worse. That is a class 3 actually by the ESC because the risk could actually outweigh the benefit because the literature is so sparse, but AHA still supports it. We do here and there at UMH fall into that category, submassive high risk with the relative contraindication, but the RV is failing and they're getting worse in front of your eyes on anticoagulation, then we do kind of agree with AHA on that one, and we do intervene on those from time to time. Contraindications, if you can't get any systemic thrombolysis, so you have an absolute contraindication, this is obviously not the best therapy because the half-life of TPA is 6 minutes. If you're infusing TPA through the catheter, the thrombus is broken up, you're going to get systemic TPA at some point. So if you have an absolute contraindication, that's not a patient that can get this device. And if you can't get any anticoagulation, this is really important. A lot of floor patients or PCU patients will have an absolute contraindication to anticoagulation at all. And if you put a big catheter into the artery, you're going to irritate the endothelium and you'll actually make the clot worse. So we have to heparinize at least transiently for that procedure. So those patients really can't get any catheter-directed therapy safely if they can't tolerate at least, it's usually about a 70 unit per kilo bolus of heparin. And that's a question that we get consulted on frequently is my patient can't get any anticoagulation, can they get one of these? And that's usually the consensus recommendation. There's a couple studies on this. So the rescue one, big problem with these devices, a lot of them are going to be industry sponsored, single arm, basically showing this is our intervention we did and did it work or not. And so that's kind of what this one was. This was a Bahir infusion catheter, 7 milligrams TPA, very low, over 4 hours. And these were submassive. So low or high risk submassive, could be not necessarily ICU level patients because you can have completely normal vitals, normal oxygenation, and fall into that category. The exclusion was submassive. So submassive patients were not included in this, which will be the theme that you'll see in a lot of these trials because ethically it's difficult to have a randomized trial and not give massive PE patients that can get thrombolysis, randomize them to potentially not getting it because that would be unethical because you're not giving a class 1 recommended intervention essentially. The results in this, so the PA obstruction of the clot went down, which is the 7 milligrams TPA, and the RV-LV ratio was improved as well at 48 hours. Very low adverse event rate. So this was one of the bigger studies that was in JACC. The next one is on the ECOS, which is the ultrasound assisted device. This was another single arm prospective. You see the theme using the ultrasound assisted device. And this is a little more TPA, 24 over 24 hours. This could be massive, but not that massive. So if you'll see the asterisks, systolic less than 80 was excluded, but if you're a systolic less than 90, you're technically massive. So they reported it as including massive and submassive, but it didn't really. It was kind of in that little sweet spot. And the results were similar. So decreased P obstruction, better RV to LV ratio, no intracranial hemorrhage, which is important because that's really the big ominous worry with TPA, especially is spontaneous intracranial hemorrhage, and there was none in this study. The last one for catheter-directed, and this is why you've seen a trend away from it in your patients. In 2019, it was a single center prospective looking at their own internal use, and they compared catheter-directed to ultrasound-assisted, and it was mainly submassive, but it was no change. So the vitals got better, the PA pressures got better without the ultrasound assist, no major bleeding, no mortality change. So that's why you've seen ECOS kind of go out of favor a little bit because it does add about $10,000 cost to compared to a regular infusion catheter. And this trial very clearly demonstrated no benefit. So the last thing I'll talk about are the mechanical or aspiration thrombectomy devices. The two most common at UMH that we like to use are the Inari FlowTriever and the Penumbra aspiration catheter. Again, I don't have any disclosures for either of these companies. It's really based on the procedural list, the interventional cardiology group or the interventional radiology group at the provider discretion, essentially. So these are more helpful for patients with absolute contraindications to lysis because you don't need any TPA. It's just an aspiration device or a wire device that removes the clot mechanically without any TPA. The evidence is a little more robust on these in terms of the number of trials. It's a 2AC recommendation from ESC and AHA. The submassive high, that last group, is another one I want to highlight, where submassive high with an absolute contraindication to ST. So if they get worse, what are you going to do? You don't have any therapy options because they can't get thrombolysis. So that group, I feel like it's helpful, but the literature just isn't there yet because there's not really a lot of RCTs. There's not a lot of good data on this. That's not a single arm industry sponsored. Contraindications are the same, where you have to at least get that heparin bolus so you don't propagate the clot by irritating the endothelium for the catheter placement. So the FlowTriever flare study, all the Inari are flare flash flame. It's really, really nice branding by their department. It was published initially in 2019 in JACC. So this was a prospective single arm FlowTriever for submassive. They excluded all massives, and same thing. So as some of the other devices, so lower PA pressures, improved RV-LV ratio, very low adverse events, so 3.8% adverse event rate. This was followed with the Flame, which was this year, and we were an enrollee site for that one, and then this one as well. We didn't have any authorship, but it was published in Circulation. Prospective parallel group, so they had a group that they followed FlowTriever versus context arm, and the context arm, the majority of the time, was thrombolysis, and these included massive PE. So this was newer in the sense that they had massive PE patients that they were intervening on with the FlowTriever and not giving lysis to. Now, the problems this caused is because the sicker patients in these two arms, the context arms, were given lysis, so they fell into the context arm essentially. So the control populations were not equal at all. The shock stages was much worse in the context arm versus the FlowTriever arm. But this study did show the decreased mortality benefit and decrease in the primary outcome with the FlowTriever arm, which was mortality, bailout to other strategies, deterioration, or bleeding. But again, not a perfect trial just because of the setup, and you're kind of stuck with these kind of trials, again, because it's hard to ethically randomize a study to lysis or catheter device. So Penumbra had a similar extract PE trial. It was prospective single arm inclusion. These were submassive again, and you excluded if you got any TPA, had pulmonary hypertension. And this was another trial, decreased RV-LV, 1.7% major event, adverse major event. So very, very, very low, very safe device. And 98.3% didn't end up needing thrombolysis. So that didn't have to get salvaged to that arm. But again, this isn't a randomized, just prospective single arm. Ongoing research. So lots of trials are ongoing at the University of Miami-Jackson specifically. So we're involved in Strike and the Storm for Penumbra. We're enrolling sites. Again, I don't have authorship interest. This is a prospective single arm that's enrolling now. Inclusion is you have to have blood pressure above 90, so your submassive group. You can't have gotten TPA. You cannot have a contraindication to anticoagulation or TPA. And then what would eliminate quite a few of the PERT patients that we follow are the active cancer. You're excluded if you have stage 3 or stage 4. This primary outcome is going to be similar, where it's RV-LV ratio, death or bleeding, and deterioration. So if you hear about this trial, and we are enrolling, so you might have a patient that is a member. And then Peerless is another one, and this is a little unique. So this is something we're enrolling where it's an RCT, and you're randomized into thrombolysis catheter or the FlowTriever, which is that mechanical one. And this is rare because if I run the Inari FlowTriever company, why would I create an RCT that could potentially show that my device doesn't work as well as this other device that there's some data on? So this is a first, not a first, but very unique. It's ongoing. It's any acute PE with submassive criteria, similar outcomes, death, major bleeding, intracranial hemorrhage. And then the last one I want to talk about is a Storm PE trial that enrolled their first patient yesterday, actually. And this is a topic in itself. So it's same as Penumbra, but they use their lightning flash system. And what that is a computer-based algorithm that helps to extract the PE using AI software. And it's very fancy. I don't know how to explain it, to be honest, but it exists. And so be on the lookout. Similar criteria to the Strike trial. So massive are excluded, submassive, and you're looking at the same thing. So mortality, primary RV to LV ratio, and they're going to add a functional component at 6-minute walk test at follow-up visit, which is nice. It's hard to enroll enough patients with that part of the study, but that's there as well. So here's kind of your summary. The IVC filters in general, we're limiting those to patients with contraindications to anticoagulation. And then if they no longer have that contraindication, it's important to emphasize removal. There's IR has a pretty established pipeline to get those removed on an outpatient basis. Lysis catheters, again, those are beneficial for relative contraindications to lysis. Ultrasound plus lysis, the benefit isn't really there. The cost is a little worse. I need to see more data to recommend it. We haven't done an ECOS really since I started UMH. Mechanical and aspiration. So those are the absolute contraindication. There's some benefit there. It is an option, but there is a little more hemodynamic issues, but that's another thing you can offer your patients. So are there any questions? I know that's a lot of information. There's a lot of gray area that I would love to help clarify if I'm able to do so.
Thank you, Dr. Gorman, for organizing those very complicated trials and things in a very clear and succinct way. Don't be apologetic, you're not an author. You should be an author of some of it. That would be a good thing. So while you're all thinking about the questions that you want to ask in the audience, I just want to ask a practical question, mainly for the baby boomers, who probably would be the ones that appear in the ED and in the ICUs with filters.
Yeah.
What is the guidance in terms of, is there a timeline where they become so epithelialized? Is there a way to know that you can't remove the filter? Or is it better just to leave it in there and not cause any problems?
So exact timeline is up to that proceduralist. My father actually has an IVC filter from the 90s that he had at the time a contraindication to, and we've gotten a couple opinions, and you can't remove it because it's at this point, it's part of his IVC essentially. It's too risky. Some of the proceduralists will say a year to 2 years. The newer devices are made to be retrieved. The older ones were not. So if you have one of those older devices, they're really not made to be removed. So that's kind of where that would fall in for the baby boomer generation, so to speak.
Thank you, Dr. Punjabi and Dr.
Yeah, the values
Repeat the
because,
question.
oh,
I heard.
so the first question was when should we be removing these devices? And I think when it's logistically feasible. So if you're inpatient and you no longer have the contraindication, I would do it before discharge, because when you go into the outpatient spectrum, it's much more difficult to arrange follow-up, ensure that they actually do come back. And the last thing you'd want is a year later, the patient is finally back in the system and now it's too late or becomes much more dangerous. 6 months or below is usually when we try to coordinate it, if you're sent to a SNF or LTAC and we're able to kind of coordinate that care a little bit. And then the second question was the RV-LV ratio. Why is that so frequently studied as a primary outcome? And the answer is because it's the easiest thing to study at 48 hours. To be honest, it's probably my take on it, is you get a repeat imaging or repeat echo. It's easy and it's objective, and you can say that that actually has benefit if the RV is better at all. But if the vitals are the same, it's a little more difficult. But I think it's just the ease of calculation.
Dr. Contreras.
Yeah, that's a great question. So that that's come up frequently, is where is this an emergency? Should we start this right away? I think if they fall into the massive, then it's an emergency to get thrombolysis. But what Dr. Dial and I were talking about before, Europeans would actually recommend trialing anticoagulation if you're in a submassive risk group for 48 to 72 hours before escalating therapy to see if they actually are failing the anticoagulation trial, and then you escalate to the lysis catheter, especially if the vitals look good, the patient clinically is well appearing. But there's not really an agreed upon timeline other than that.
Okay, perhaps one more question,
Mhm.
just from a practical standpoint. So patient comes in, they're in the, they're brought up to the cath lab to confirm this PE.
Mhm.
I would imagine the decision needs to be made then and there, because you're not going to send them back, and then bring them back up again and decide what you're going to do. So how does it logistically work at 10 o'clock at night on a Saturday that you decide which one of these interventions you're going to do?
So that's kind of where the PERT team is really helpful because we coordinate discussions with everybody. So we'll have a discussion with the interventional cardiology team, interventional radiology team at the time to see, especially those submassive high risks that maybe the blood pressure is normal now, but the RV really looks bad on echo and maybe they're a little tachycardic and getting a little worse. So you have the discussion essentially right when the PE is diagnosed. We use artificial intelligence software as well, so I get alerts on every pulmonary embolism. So we're able to activate it very quickly. And then we can come up with a plan, and the plan can also be, let's trial anticoagulation for 12 or 24 hours and then see. But the multidisciplinary discussion happens right away because you have to, especially on the weekend, you have to mobilize the cath lab, mobilize resources. So it takes a little bit of time.
Thank you, Dr. Gorman. Thank you, Dr. Shukla.